Welcome to this explainer. Today, we are going to unpack the incredibly dense, complex clinical pathway of breast cancer. We're going to take you all the way from basic human anatomy right through to advanced surgical treatments. And we'll be doing all of this by looking directly at structured medical notes and real clinical data. Here is our roadmap for today, which actually mirrors the exact logical journey a clinician takes. 1. Anatomy of the breast. 2. The triple assessment. 3. Genetics and classification. 4. A real-world clinical case. And 5. Surgical treatment options. Let's get right into it with Section 1, Anatomy of the Breast. To really understand the disease, we first have to understand the baseline. Think of breast tissue essentially as a highly modified sweat gland. You'll notice how it sits directly over the pectoralis major muscle, extending vertically all the way from the second down to the sixth rib. Grasping this specific physical boundary is absolutely essential for surgeons when they're determining exactly how much tissue needs to be removed. Now, a really crucial piece of this anatomical puzzle are the suspensory ligaments of Cooper. Basically, these are fibrous bands that extend outward from the underlying pectoralis fascia and attach right to the skin. They act a lot like structural anchors, primarily supporting the lower half of the breast tissue. So, what does this internal theory actually look like in external clinical practice? Well, on the left, if a cancerous tumor infiltrates and pulls on those suspensory ligaments of Cooper we just talked about, it causes visible external skin dimpling. But on the right side, if that cancer instead invades the lactiferous ducts, which are the 15 to 20 ducts opening right at the nipple, it pulls those inward, resulting in nipple retraction. It's two completely different structural invasions, giving us two distinct visual clues. Which brings us to Section 2, the triple assessment. Medicine absolutely hates to guess, right? That's exactly why we have this mandatory diagnostic protocol, universally known as the triple assessment. It provides 3 independent, overlapping safety nets to catch a malignancy. You always start with a clinical exam and history, then you confirm what you feel with radiological imaging, and finally, you definitively prove what it is under a microscope with a histopathology biopsy. During the radiological step of that assessment, mammograms give us some incredibly specific visual clues. Benign masses often display larger, coarser macrocalcifications, and they usually possess a very distinct, well-differentiated halo around the lesion. Malignant tumors, on the other hand, behave aggressively. They show up as architectural distortion, microcalcifications, and have these irregular, spiculated borders. Just look at this striking visual contrast between containment and straight-up invasion. On the left, in the craniocaudal view, you can clearly see the smooth, well-contained shape of a benign fibroadenoma. Now contrast that directly with the medial-lateral oblique view on the right. There, you see the chaotic, irregular spread of a malignant, spiculated lesion. The visual difference there is just night and day. Because capturing this imaging is literally a lifesaver for early detection, an annual screening mammography is standardly initiated at 40 years of age. Catching those tiny microcalcifications early is quite simply the best screening method we have. And the data backs this up. It effectively reduces overall mortality by 15 to 20%. Moving right along to Section 3, Genetics and Classification. Now, genetic screening is an absolute game changer in this field. Take the BRCA1 mutation, for example. It is a notoriously aggressive driver pushing a patient's lifetime breast cancer risk to a staggering 60 to 80%. Plus, BRCA1 also heavily predisposes a patient to ovarian cancer at a 20 to 40% risk, which is significantly higher than what we see with the BRCA2 variant. Identifying this gene completely changes the entire timeline and strategy of a patient's care. Let's see how this all connects in Section 4, a real-world clinical case. Let's ground all these dense medical facts into reality. Our case study today focuses on a 45-year-old woman who arrived at the clinic with a deeply concerning chief complaint. She had a lump present for 6 months with an insidious onset, and it had grown rapidly from a modest 2 centimeters to a massive 10 by 10 centimeters. Digging into her history, things get really alarming. She experienced recent ulceration accompanied by a foul-smelling discharge, which clearly indicates tissue necrosis. Yet, despite this rapid, aggressive local progression, she interestingly kept a normal appetite and showed absolutely no systemic signs like bone pain or jaundice. Those are clues that would normally indicate the cancer had metastasized or spread to distant organs like the spine or liver. And here is the objective and, honestly, quite severe visual evidence of her condition upon examination. We see a massive, fungating growth localized right in the upper outer quadrant of the right breast. The ulceration is severe, it has irregular, everted edges, and the clinical notes state that it bleeds simply by being touched. So, combining our triple assessment protocol with this physical presentation, the clinician's definitive diagnosis is a locally advanced breast carcinoma. Specifically, it's staged as T4B. The 4B classification is explicitly used here for one reason. The tumor has directly involved the skin, resulting in that severe ulceration and fungating mass we just saw. Which brings us to our final part, Section 5, surgical treatment options. When surgeons evaluate early or operable stages, they are usually weighing a targeted breast conservation surgery against a total mastectomy. And you know what? The data here is totally fascinating. The overall survival rate between the two procedures is remarkably identical. However, the conservative surgery does carry a slightly higher local regional recurrence rate, about 3 to 4% compared to less than 1% for a mastectomy. Because of that slight bump in recurrence, mandatory post-operative radiotherapy becomes an absolute requirement if you go the conservative route. To actually make that conservative surgery viable and cosmetically acceptable, surgeons use these brilliant oncoplastic techniques. It's almost like a structural puzzle. Notice how techniques like volume displacement allow the surgeon to safely extract the tumor with totally clean margins, making sure zero cancer cells remain at the edges, while strategically mobilizing the remaining breast tissue to close the defect and preserve the breast's natural shape. Of course, surgery is never without risk, right? If a patient's cancer has spread to the lymph nodes and requires extensive axillary clearance beneath the arm, nearby motor nerves are placed at really high risk. Injury to the long thoracic nerve during this clearance can unfortunately lead to permanent functional impairments. This results in a condition called winging of the scapula, which profoundly affects the everyday mechanics of the patient's shoulder and back. As we wrap up this explainer, I want to leave you with a final thought. We just saw that the physical mechanics of treating this disease are complex, and they carry heavy physical risks. So, if conservative surgery and radical mastectomy yield the exact same overall survival rate, how do we best balance ruthless, objective clinical survival statistics against the deeply personal, long-term quality of a patient's life? It really is the ultimate question at the heart of modern medicine.